Today I will be discussing sleep-related eating disorder. Everybody sleeps. In general, people cycle through 4 defined sleep stages that alternate between rapid eye movement sleep, non-REM sleep, and sometimes wake. This cycle is regulated by our circadian rhythm. In certain instances, however, people may suffer from disorders of sleep, in which sleep can be significantly impaired and cause many consequences. Between 1 and 5% of adults have parasomnias, and today I will discuss sleep-related eating disorder more specifically. Sleep-related eating disorder is a non-REM sleep parasomnia characterized by recurrent episodes of dysfunctional and involuntary eating that occur after an arousal during the main sleep period. It is associated with diminished levels of consciousness and recall, but levels of consciousness can range from full to no awareness. Episodes generally include compulsive and rapid ingestion of food. Currently, the International Classification of Sleep Disorders, 3rd edition, included sleep-related eating disorder as an arousal disorder during non-REM sleep. It is very important to note how many problems this disorder can cause people. The most common adverse effect is weight gain due to the repeated consumption of high-caloric foods during episodes. Other significant consequences are psychological distress due to lack of control and guilt of nocturnal eating, daytime fatigue from disrupted sleep, and injuries involving falls, burns, and cuts while searching for and preparing food. People may also ingest abnormal or toxic substances. In terms of prevalence, sleep-related eating disorder can affect all genders and ages, generally starting in young adults. However, there is a female predominance with around 66 to 83% of cases being women. The prevalence in the general population is not well established but has been estimated to be between 1 to 5% in adults. In a study done by Winkleman and colleagues, they found it could be as high as 16.7% in patients who have eating disorders. During sleep, people with sleep-related eating disorder arouse usually during the first few hours of sleep, often during stage 3 non-REM sleep, where brainwaves are very slow delta oscillations. Episodes may occur from the transition of one sleep cycle to the next, and often it is impossible to wake someone up during an episode. The image shown here is a polygraph during an episode of sleep-related eating. The pathophysiology of the disorder is largely unknown, although the dopaminergic system might be involved. Furthermore, like many other parasomnias, sleep-related eating disorder has proven to be highly comorbid with other sleep disturbances, in particular, somnambulism, narcolepsy, periodic limb movement disorder, restless leg syndrome, and obstructive sleep apnea. In a study by Schenk and colleagues, they reviewed 8,000 patients in a sleep disorder clinic. The polysomnography found that of those diagnosed with sleep-related eating disorder, over 70% of these patients suffered from sleepwalking, and 10% had a current or past diagnosis of anorexia nervosa. The primary cause of sleep-related eating disorder is not known. However, many of its comorbid sleep disorders have a genetic influence. Additionally, approximately 20% of the patients in one study had a first-degree relative with sleep-related eating disorder. However, no specific genetic link has been found so far. Some medications, such as some sedative hypnotic drugs, antipsychotics, and antidepressants, may induce the disorder. Risk factors include having other sleep, mood, or anxiety disorders, being female, and daytime fatigue or stress. So, what can we do to treat it? Currently, many different forms of treatment are being employed for this disorder. Most commonly, treatment is directed towards underlying sleep disorders using medication. Currently, there is very little evidence that changes in diet or lifestyle are effective, although certain changes such as limiting the intake of alcohol or smoking, avoiding sleep deprivation, and maintaining a consistent sleep-wake cycle are highly suggested and beneficial. Further, an example of a non-pharmacological treatment is continuous positive airway pressure for patients with obstructive sleep apnea. By treating the primary sleep disorders, 79% of patients also resolve their sleep eating behavior. Pharmacological treatment is the most widely used treatment, and a large variety have been employed. A study by Schenk et al. Found that dopaminergic agents were effective in 52% of their cases with sleep-related eating disorder, and benzodiazepines were effective in 37%. Treatments for eating disorders, such as selective serotonin reuptake inhibitors, can also be beneficial in controlling nighttime eating episodes. A large majority of treatment is done with topiramate, an anticonvulsant, which may work to suppress arousals produced by underlying sleep disorders or as an appetite suppressant. In a study by Winkelmann and colleagues, patients with low wakefulness and memory who used topiramate experienced significant reductions in the number of nights eating compared with placebo participants. However, groups with high levels of wakefulness and memory did not show this difference. Topiramate was also associated with significantly greater weight loss than the placebo. Side effects were common, but were generally mitigated by keeping topiramate doses low. So, sleep-related eating disorder can be of great concern for those affected, but luckily, sleep disorders have been gaining more focus in research as sleep is such a crucial aspect of our health and well-being. Even though much progress has been made, further controlled clinical trials using pharmacological agents and other methods of treatment are warranted. Thank you for listening, and please check out these articles for further information.